Hello, dear friends. Once again, we are going to continue our series of applied neuroanatomy, and we are shifting now from the central nervous system to the peripheral nervous system, and we'll start by discussing the anatomy and the surgical exposure of the brachial plexus. First of all, when discussing the anatomy, of course, you all know about the brachial plexus and the anatomy of the brachial plexus, but we'll concentrate about in this case about the applied exposure of the brachial plexus and the surgery of the brachial plexus from an aspect different from the classic anatomy. We start by the classic anatomy, and as you all know, the brachial plexus is formed from the 5 roots from C5, C6, C7, C8, and T1, and it has 3 trunks, an upper, middle, and lower trunks, and it has 3 anterior divisions, 2 forming the lateral cord and 1 forming the medial cord, and 3 posterior divisions forming the posterior cord. The 3 cords are named medial, lateral, and posterior according to the relation to the second part of the axillary artery in the arm. So this is the view of diagram of the brachial plexus. As we said, we have the 5 roots. The upper 2 roots, 5 and 6, form the superior or upper trunk. C7 continues as the middle trunk. C8, T1 form the lower trunk or the inferior trunk. And then these are the trunks of the brachial plexus. And then to form the cords, we have anterior and posterior divisions. The posterior division is very classic. So 1 division from each trunk unite together forming the posterior cord, and the anterior cord, we have the lateral and the medial cords. The lateral cord is formed from the anterior division of the upper and middle trunk, and the medial cord is formed as a continuation of the inferior or the lower trunk. We can also see here the branches of the brachial plexus, branches arising from the roots of the brachial plexus, which are the dorsal scapular nerve, nerve to rhomboid, nerve to subclavius, and the long thoracic nerve or nerve to serratus anterior. And 1 branch to 3 branches from the roots, 1 branch from the upper trunk, which is the suprascapular nerve, and we get other branches from the anterior cords and the trunks of the brachial plexus, like the medial pectoral nerve, the medial cutaneous nerve of the arm and the forearm, and posteriorly we have the upper subscapular nerve, lower subscapular nerve, and the thoracodorsal nerve, or the nerve to the latissimus dorsi. And this is from the lateral root we get the lateral pectoral nerve, and then the posterior root divides into the radial nerve and the circumflex or the axillary nerve, and then the cords form the nerves, which are the letter M, the median nerve having a division from the lateral root, division from the medial root, and medially the ulnar nerve, and laterally the musculocutaneous nerve. So this is the M. So again, branches from the roots, nerve, dorsal scapular nerve, nerve to subclavius, long thoracic or nerve to serratus anterior, branch from the upper trunk, suprascapular nerve, and then the divisions, anterior and posterior. The anterior division of the upper and middle trunk form the lateral cord, and the continuation of the lower trunk form the medial cord, and the posterior divisions form the posterior cord, and the branches of the posterior cord are upper subscapular, lower subscapular, thoracodorsal nerve, and ending by the radial and the axillary. And from the lateral root we get the lateral pectoral nerve. From the lateral cord we get the lateral pectoral nerve, From the medial cord we get the medial pectoral, medial cutaneous nerve of the arm and the forearm, and the nerve ends by forming the M, two divisions of the median nerve, ulnar nerve medially, musculocutaneous nerve laterally. Another view of the brachial plexus showing the anterior divisions and the posterior divisions, and another view in the neck showing the roots, the trunks, the divisions behind the scapula, and the cords in relation to the axillary artery. This is a cadaveric view showing the clavicle and showing that this is the supraclavicular and this is the infraclavicular pathway of the brachial plexus. The other view, 5 roots, upper C5, C6 forming upper trunk, C7 middle trunk, C81 lower trunk, and each trunk dividing into anterior and posterior divisions, posterior division forming posterior cord, and the lateral cord is formed by the junction of the upper and middle trunk, and the medial cord is the continuation of the lower trunk. An operative view again showing the brachial plexus and the supraclavicular part of the brachial plexus showing the upper trunk, the middle trunk, and the lower trunk. And we said that the upper trunk together with the middle trunk, they form the lateral cord, and the lower trunk continues as the medial cord, and the posterior divisions from the 3 trunks form the posterior cord. Another view, roots, trunks, divisions behind the clavicle, cords in relation to the second part of the axillary artery, branches, and the nerves. So the supraclavicular part of the brachial plexus, we are talking about the posterior triangle of the neck, and we are talking about the lower part of the posterior triangle, what we call subclavian triangle or the supraclavicular triangle, bounded by the sternomastoid anteriorly, clavicle below, and the inferior belly of the omohyoid muscle superiorly. In this part we expose the brachial plexus, as you will see. These are the triangles, and we are concerned with the supraclavicular or subclavian triangle, part of the posterior triangle of the neck. This is a view showing how the brachial plexus passes from the neck behind the clavicle down to the arm, and first of all here we are displacing the sternomastoid anteriorly. We find a muscle called the scalenus anterior and a nerve on this muscle, which is the phrenic nerve stamped on the surface, and then behind this muscle we have the brachial plexus and the subclavian artery, and it is between the scalenus anterior and the scalenus medius neurovascular bundle. Another view, so this is the scalenus anterior, the scalenus medius, and between them the roots of the brachial plexus and the second and third part of the subclavian artery. So we have here from proximal, this is the first part of the subclavian artery, which is medial to the scalenus anterior. The second part posterior to the scalenus anterior. The third part is lateral to the scalenus anterior, and the brachial plexus is here. Another view, again, sternomastoid displaced anteriorly. Under cover of the sternomastoid is the scalenus anterior, phrenic nerve C3, 4, and 5, which is stamped over the surface of the scalenus anterior and passing from lateral to medial, and Then we have the trunks of the brachial plexus between the scalenus anterior and the scalenus medius. And of course you find the branches of the subclavian artery, transverse cervical, and suprascapular arteries. Again, scalenus anterior, as you will see later on here, is a very important muscle in the supraclavicular exposure of the brachial plexus. So you have to identify it, and the brachial plexus is just behind it as well as the subclavian artery. This is to show you that superficial to the scalenus anterior and at a lower level is the subclavian vein. So subclavian vein, scalenus anterior with phrenic nerve attached to the surface, stem to it, passing from lateral to medial, then the subclavian artery and the trunks, the roots and the trunks of the brachial plexus and the scalenus posterior. Again, scalenus anterior, the neural bundle and the vascular bundle, the scalenus posterior and the phrenic nerve and the clavicle, and then passing as the axillary artery medial to the coracoid process. The infraclavicular part, infraclavicular anatomy, is showing the cords of the brachial plexus after leaving the clavicle. After having the divisions, we have the first part of the axillary artery below the clavicle, which is medial or proximal to the pectoralis minor. The second part is behind the pectoralis minor, and the third part is distal to the pectoralis minor. And we have the lateral cord, medial cord, posterior cord in relation to the second part of the axillary artery under cover of the pectoralis minor. More about the axillary part, infraclavicular part, is covered by the pectoralis major muscle, and the coracoid process is a stable bony landmark. Always the brachial plexus is medial to it and below it. So this is the coracoid process. If this is lateral and this is medial, brachial plexus will be here. Why we are talking about the coracoid process? Because sometimes, or many cases of distorted anatomy after injury, whether open or closed injury, whether there is a hematoma and adhesions, you need a bony landmark to identify where you are. Coracoid process is an excellent bony landmark, giving the insertion or of the pectoralis minor, and what is medial to it and below it is the brachial plexus. Again, showing the removal of the pectoralis major, we find the pectoralis minor and we find the brachial plexus giving the cords under cover of the pectoralis minor and medial to the below the coracoid process. Contents of the axilla, of course you know it. It contains the axillary artery and branches, contains the cephalic vein, artery and vein. It contains the cords of the brachial plexus, which is the infraclavicular part of the brachial plexus, medial, lateral, and posterior cord, and contains some of the branches arising from the trunk of the brachial plexus, axillary lymph nodes, and loose areolar tissue. Another view, the whole journey of the subclavian changing into axillary and the brachial plexus. A cadaveric view showing the artery and the nerves passing from the neck to the arm. This is a coronal view of a case of avulsion of the brachial plexus, which is common especially in motorcycle accidents where the riders are wearing a helmet protecting their skull, so they get a rotation and side bending of the head, producing traction, and this traction can cause what we call pseudomeningocele related to avulsion of the root. Very bad prognosis. The only solution if the root is avulsed is neurotization and we'll see it in the next chapter. Surgery of the brachial plexus. In this talk, we are going to concentrate on how to expose the brachial plexus, and the next chapter, the next talk, will be about technique of brachial plexus and nerve repair, what to do after we expose it. But here we concentrate on the exposure. So in managing brachial plexus injury, we have a very simple algorithm. The injury is either open by sharp instrument or closed. If it is open, it is causing laceration and transection. If it is sharply divided and clean, we can do a primary repair up to 3 days. Peripheral nerves up to 6 hours, but here, because the prognosis of surgery is not that good, we can wait 3 days and do reanastomosis. But if the open injury producing contusion and discontinuity of the epineurium, you just tack the edges adjacent plain tissue to be repaired at 3 weeks, and we'll say 3 weeks in the next chapter. Or it is a closed injury. Closed injury is more common than the open injury, and it could be related to traction, which is stretch of the nerve, could be producing contusion, could be producing compression of the nerve, or ischemia, or electric injury, or wrong injection, or iatrogenic injury when you are doing some physiotherapy or abnormal movement of the neck and traction on the nerve. If it is a closed injury, it needs evaluation by continuous clinical assessment, EMG, radiographs, CT myelography, and MRI. And most important is the MRI, and we'll see what's going on. If there is regeneration, so nothing to be done more. If there is no regeneration, we wait for 3 months. In peripheral nerves, we wait for 3 weeks. But here we wait for 3 months because the prognosis is not that good as the peripheral nerves. If there is no improvement in closed injury after 3 months, you explore the place. If there is adhesions, you can do neurolysis. If there is contusion of a part of the nerve, you can do reconstruction. Or if the nerve is totally fibrosed, we can do neurotization. So, closed injury, again, as we said, open injury, primary repair, or tacking, and 3 weeks later repair. Closed injury, evaluation, any regeneration or recovery, so wait. If there is no signs of recovery within 3 months, you do the exploration. Regarding the anatomy and the exposure of the brachial plexus, there are pearls in brachial plexus surgery, comparing between the scalenus anterior and the pectoralis minor muscles. These are the two most important structures and the keys to the supraclavicular exposure and infraclavicular exposure. So the scalenus anterior is the pearl of the supraclavicular approach, and the pectoralis minor is the pearl of the infraclavicular approach. The scalenus anterior is covered by a muscle, which is the sternomastoid, and the pectoralis minor is also covered by a muscle, which is the pectoralis major muscle. In order to expose the scalenus anterior, you displace the pectoralis sternomastoid anteriorly. In order to expose the pectoralis minor, you displace the pectoralis major inferiorly. And the scalenus anterior is identified by the phrenic nerve on its surface, passing from lateral to medial as we saw, stamped on its surface. Pectoralis minor is identified by the coracoid process, which giving the insertion of the muscle, and when you find the coracoid, the pectoralis minor is medial to it. Another pearl, the scalenus anterior, cover the trunks of the brachial plexus, which are 3 trunks, upper, middle, and lower trunk, as well as the second part of the subclavian artery, and you can cut it to expose them. The pectoralis minor also cover 3 cords. These are 3 trunks. the pectoralis minor covers the three chords. The pectoralis major, the scalenus anterior, has the second part of the subclavian artery, while the pectoralis minor covers the second part of the axillary artery. So, three trunks, three chords. Second part of the subclavian artery, second part of the axillary artery. And as we said, scalenus anterior is exposed by retracting the sternomastoid anteriorly. Sometimes when you open in this triangle, the subclavian triangle, or the supraclavicular triangle, say I couldn't identify the scalenus anterior, you have to push the sternomastoid anteriorly to see it, and the pectoralis minor is exposed by retracting the pectoralis major inferiorly, as we'll see, and the clavicle covers the divisions. So scalenus anterior is the anterior cover of the trunks. The pectoralis minor is the cover of the chords, and the clavicle behind it are the divisions of the brachial plexus. The supraclavicular approach, you do a transverse incision above the middle third of the clavicle. That's enough. You can extend it by doing an extension to the posterior border of the sternomastoid, and you do here a round tip to preserve the skin. So you can do it only transverse incision or a transverse and retromastoid incision. This is the view, sternomastoid. I am behind sternomastoid and below the inferior belly of omohyoid. And of course, these are the cutaneous branches of the cervical plexus. We are not going to discuss it here, but when you open, you can be facing some of the cutaneous branches of the cervical plexus, which are not really important, supraclavicular branches. And then you find a pad of fat behind the sternomastoid and below the omohyoid. And when you displace the scalenus anterior, when you displace the sternomastoid anteriorly, and when you displace the scalenus anterior, or you cut it, you will find the roots and trunks of the brachial plexus. So you will find C5, C6 giving the upper trunk, C7 continuation of the middle trunk, and C81 forming the lower trunk. Another important thing is that the upper trunk is the most superficial, middle trunk is deeper, and lower trunk is the deepest. So that, like stairs, you go from superficial to deep. 5, 6, upper trunk. 7, middle trunk. 81, lower trunk. Again, 5, 6, upper, 7, middle, 81, lower trunk. And again, you see here the roots, then the trunks, then the divisions. You see that 5, 6 is the most superficial, and C8, T1 are the most deep, passing like that. Thoracic duct, you should know that there is something called thoracic duct, carrying the chyle, carrying the lymph from the abdomen up. The left side we get the right lymphatic duct, and in the right side we get the famous thoracic duct. You should know that it opens at the junction of the subclavian vein, internal jugular vein, and the relation, it is medial to the scalenus anterior muscle. So, if you decide to cut the scalenus anterior, you should cut it cautiously because the lymphatic duct or the thoracic duct is opening medial to it. But the structures concerning us, brachial plexus, subclavian artery, are lateral to it. We study this relation. Again, the thoracic duct, medial to the scalenus anterior, phrenic nerve passing from lateral to medial, and the brachial plexus subclavian artery, lateral. Operative view of thoracic duct and the infraclavicular approach. We talked about the supraclavicular approach. Incision is in a very famous place you all know. This is the pectoralis major muscle. This is the deltoid, and we have here what we call the deltopectoral groove. Deltopectoral groove. So between the deltoid muscle and the pectoralis major, and you do your incision here. Sorry. You do your incision here between the deltoid and the pectoralis major. And you open, if you reflect the pectoralis major down, this inserted from the clavicle, you start to see the pectoralis minor and the clavipectoral fascia. This is a cadaveric view of the pectoralis major muscle. This is after this insertion from the clavicle. See the clavipectoral fascia between the pectoralis minor and the clavicle, and pierced by the cephalic vein, pierced by a nerve, lateral pectoral nerve, and pierced by an artery, thoracoacromial artery. It's not that important. And again, when you displace the pectoralis major down, remember when we displaced sternomastoid anteriorly, here we displace the pectoralis major down, you find the pectoralis minor, you find the coracoid process, and you find the brachial plexus deep to the pectoralis minor, together with the axillary artery, forming the cords of the brachial plexus. And here I'm putting my finger with the axillary artery, with the cords of the brachial plexus under the pectoralis minor muscle. Here is the clavicle, and here is the lateral cord, laterally. Here the posterior cord. How can I see the posterior cord? Because I reflected the axillary artery medially. So the cord, posterior cord, is posterior to the axillary artery, and the lateral cord is lateral. It's not that apparent here, but it is lateral here. Another view. Here is the lateral cord, and here is the axillary artery. Here is posterior cord, and here is the medial cord. Lateral cord, lateral to the axillary artery. Posterior cord, posterior to the axillary artery. Second part. Medial cord, medial to the axillary artery. We can combine a supra and infraclavicular approach. We can do above, as we said, the upper third of the clavicle. You can extend it along the posterior border of sternomastoid, or you might not extend it. And then you go in the deltopectoral groove and you do your incision. And this is for the tricks for the exposure of the brachial plexus. We will talk about the management of brachial plexus injury in the next chapter, which is the techniques of nerve repair, brachial plexus and nerve repair and neurotization. But here I have to mention that there is a very special entity and quite common, especially in developing countries, of birth injuries of the brachial plexus due to obstructed labor and difficult delivery. And this can result in three things. Erb's palsy, if you injure the upper roots and the upper trunk, call it waiter's tip paralysis. We'll see why we call it like that. Sometimes they call it policeman tip paralysis, and it has a very good prognosis. Why? Because it is supplying a small group of large muscles. Klumpke's palsy is the lower trunk of the brachial plexus, C8 dorsal 1, loss of small muscles of the hand, bad prognosis because it is supplying a big group of small muscles, and total stretch or avulsion of the brachial plexus has the worst prognosis. So herbs, you find that there is extension and there is 5, 6, there is extension. We cannot flex because 5 and 6 biceps is affected, brachialis is affected. There is pronation and there is flexion of the wrist. So as if he is receiving a tips in a secret way. Porter's tip paralysis, waiter's tip paralysis, policeman tip paralysis, whatever you want, prognosis is good. Klumpke's paralysis, you will develop wasting of the small muscles of the hand, so you get the claw hand deformity, and you know C81 lower trunk supplies the small muscles of the hand, and the prognosis is not good. And total stretch or avulsion of the brachial plexus, get complete paralysis of the nerve, of course, the prognosis is bad. And thank you very much for your attention. And the next lecture, as I said, is a very close continuation of this one, but I decided to divide it into 2 episodes, because in this case you should concentrate on the anatomy and how to expose the brachial plexus supra and infraclavicularly, and then we'll tell you what is the technique of repair and what should be done when you repair the brachial plexus or other peripheral nerves. Thank you for your attention, and we hope we meet very soon.